Good afternoon everyone. As a part of integrated museum teaching, this week's topic is nose and ear. Okay, so I'll be talking briefly about the anatomy of the ear using this ear module. Okay, here, as you all know, it is made up of three parts: the external ear, internal ear, middle ear, and the internal ear. External ear is the outward projected part. It is made up of two parts. What are the two parts? The external ear, it's the auricle or the pinna, and the external acoustic meatus. Okay. Middle ear and inner ear is the most neglected part, as we don't see it usually in the dissection because it is a small area which is hidden within the petrous part of the temporal bone. So as you all see, this is the external ear or the pinna. This is the anterior wall of the external acoustic meatus. So we can remove the anterior wall in this model. Okay, the anterior wall is removed. So what you see here is the external acoustic meatus, which is 24 millimeter in length. The lateral 1/3 is made up of cartilage. It is a cartilaginous part which is continuous with the cartilage of the auricle. So auricle is made up of single piece of yellow elastic cartilage. This cartilage will continue with the lateral 1/3 of the external acoustic meatus. The medial 2/3 is bony. The medial 2/3, 16 millimeter, is bony, and lateral 1/3 is cartilaginous. It extends from the bottom of the pinna till the tympanic membrane. So the cavity what you are seeing here is the middle ear cavity, which is present within the petrous part of the temporal bone. Okay. So this is the roof of the middle ear, which is made up of very thin plate of bone called as tegmen tympani. So this is a tegmen tympani, which is a thin plate of bone which separates the middle cranial fossa from the tympanic cavity. So the temporal lobe of the cerebrum will be on the middle cranial fossa. So now I am removing the roof of the middle ear cavity. This is the tegmen tympani. What you are seeing here, this is the, what is this? This is the tympanic membrane, which forms the lateral wall of the middle ear cavity. So middle ear is a small biconcave shaped cavity which is present within the petrous part of the temporal bone. This tympanic membrane forms the lateral wall of the middle ear. So we can even disarticulate the tympanic membrane. So this is the tympanic membrane with its lateral surface which is projecting outside, and this is the medial surface which is pulled towards the middle ear cavity. So this tympanic membrane, medially it is convex and laterally it is concave. This convexity, medially it is pulled by the handle of the malleus which is attached to the tympanic membrane. Okay, tympanic membrane is made up of all the three germ layers: ectoderm, endoderm, and mesoderm. The outside is ectoderm, which is lined by skin, which is continuous with the skin of the auricle and external acoustic meatus. The inner layer is lined by mucous membrane, which is continuous with the mucosal lining of the middle ear cavity. And middle layer is a fibrous layer which is mainly derived from the mesoderm. Okay, so it is made up of three layers: outer skin, that is ectoderm derived, inner mucous membrane, endoderm derived, and the middle mesoderm, middle fibrous layer which is derived from the mesoderm. Okay, if we see the inner aspect, the handle of malleus is attached to it. Okay, so this is the handle of the malleus, the head of the malleus. This is the anterior process, and this is the lateral process which is attached to the tympanic membrane. So this tympanic membrane is divided into two parts by the malleolar folds. There are two malleolar folds, anterior and posterior malleolar fold, which extends from the lateral process of the handle of malleus. The part which is above the malleolar fold is called as pars flaccida. The lower part is called as pars tensa. The tensa, it is tensed, it is stretched by the handle of malleus. Okay. The head of the malleus will articulate with the body of the incus to form a saddle shaped incudo malleolar joint. So in this way, The malleus is attached to the incus. This is the long process of the incus which articulates with the head of the stapes by a ball and socket incudostapedial joint. So in this way, these three tiny bones will form a ossicular chain across the middle ear cavity for the conduction of sound. This intact chain is very essential for the conduction of the sound. This tympanic membrane is not like exactly horizontally situated. It is inclined at an angle of 55 degree with the floor of the external acoustic meatus. Okay. The long process has got a slight bend, that is called as lenticular process, which will articulate with the head of the stapes. Stapes has got the head, the neck, two crura and a foot plate. The foot plate fits into fenestra vestibula, or the oval window of the inner ear. Okay. So now if you see this model, we have the anterior wall of the middle ear. So anterior wall has got two bony canals. The lower canal is for the canal for, upper one is the canal for tensa tympani, lower one is canal for eustachian tube, bony part of the auditory tube. This tensa tympani will go and attach to the handle of the malleus, upper end of the handle of the malleus. Whenever the tensa tympani contracts, what happens? It pulls the tympanic membrane towards the middle ear cavity. Okay. So this is the lower canal which is formed by the bony part of the auditory canal, and this is the upper canal for the tensa tympani. This tensa tympani is supplied by mandibular nerve. Okay. It's a nerve of, it's a muscle of the first arch which is supplied by the nerve of the first arch. Posterior wall of the middle ear is formed by the mastoid antrum, which contains mastoid air cells is there. Through adductus to antrum, the middle ear cavity will communicate with the mastoid antrum. Okay. So in this model, you can see the anterior wall as well as the posterior wall. The lateral wall is the tympanic membrane, which is removed now. Now we will go into the inner ear. Okay. So inner ear mainly contains bony labyrinth and membranous labyrinth, isn't it? So bony labyrinth is made up of cochlea, vestibule and semicircular canals. This is a cochlea, you can see, like a snail. It has got 2.5 or 2/3/4 turns like a snail. The basal turn, the intermediate turn and the top, the topmost turn. So it forms a 2.5 turns. And then this is the vestibule, which has got saccule and utricle, which is a part of membranous labyrinth, and these are the three semicircular canals. Okay. Cochlea has got cochlear duct within it. So we can see, after removing a section, in a section, can you all see the center bony pillar is called as modulus. Around the modulus, the cochlea takes a turn. Okay. So all these are cochlear ducts, what you are seeing. So cochlear ducts contains the spiral organ of Corti, which is the main receptors for hearing. Okay. So and these nerves which are coming are the cochlear nerve and the vestibular nerve, you can see. The vestibule mainly contains saccule and utricle, mainly for the static equilibrium. The semicircular canals are 3 in number. Okay. If it is kept in the anatomical position, okay, this is the superior semicircular canal, one is the lateral semicircular canal, the other one is the posterior semicircular. Superior and anterior is one and the same, and then the lateral semicircular canal and the posterior semicircular canal. If it is kept in the anatomical position, you can see it. Okay, in this position, the one which is, can you all see? Okay, I lift. This is a superior or the anterior. This is the posterior. This is the lateral semicircular canal. Okay. So this semicircular canal is also responsible for the equilibrium. Okay. One is the static equilibrium, which is present within the vestibule, that is saccule and utricle. The maculae, which is present here, is for the kinetic equilibrium. Now, after closing the roof, Now the pittress part of the pittress part is closed by the tegment tympanic. Okay. The posterior part. Can you see a foramina here? So the nerve which is coming out through the foramina is the vestibulocochlear nerve. So what is this foramina here? Internal acoustic meatus, which transmits 7th, 8th and the labyrinthine vessels. So internal acoustic meatus. Okay. So the main content of the middle ear is a air-filled space which mainly contains the 3 tiny bones called as ossicles, which forms an ossicular chain across the middle ear. Stapes is the smallest bone. So the head of the stapes is attached by a smallest muscle in the body. That smallest muscle is the stapedius muscle, which comes from the pyramidal eminence, which is present in the posterior wall. Okay. So all this, the stapedial contraction and tensor tympanic contraction will pull those stapes, and then all the chain will move together in an axis. That will be dealt in detail by the physiology part, by the physiology of hearing. Okay. So the 3 tiny bones are the main contents of the middle ear cavity: the malleus, the incus and the stapes. Is it clear? So this is in brief about the anatomy of the middle ear. We have mounted 3 ear ossicles in this syringes. There is malleus, incus and stapes. All of you can go through it. And then we have kept the models of ear, models of the nasal septum, lateral wall behind. So after your class, after all the demonstration, you can go and have a look into it. You can pass together all. Any doubts? If you want to see the model near, you can see after all the demonstration, you can come closer, have a look into the model. Okay?
Because theory part is not at over there, but I will give you a beautiful video where it will show you the details of the theory, not exactly the theories of hearing, but how exactly the hearing takes place. So all those details are there. Middle ear is mainly in physiology. We talk about amplification thing and the impedance matching and all. So inner ear, all those things for conduction and after conduction, what exactly, how hearing takes place, all those details are there in this video. Please go to that video. If any doubts are there, please enjoy them.
The sense of hearing is accomplished by a process known as auditory transduction. The ear converts sound waves in the air into electrical impulses, which can be interpreted by the brain. As sound enters the ear, it passes through the external auditory canal, where it meets the tympanic membrane. The tympanic membrane then vibrates in response to the sound. Sounds of a lower pitch or frequency produce a slower rate of vibration, and sounds of lower volume or amplitude produce a less dramatic vibration. Higher frequency sounds produce faster vibrations. The tympanic membrane is cone-shaped and articulates with a chain of 3 bones called the Auditory Ossicles. They consist of the malleus, the incus, and the stapes. The movements of the tympanic membrane vibrate the ossicles, passing on the information of frequency and amplitude. The three bones pivot together on an axis shown here in red. The pivotal axis is due to a series of ligaments which hold the bones in place within the middle ear cavity. The anterior malleal ligament and the posterior incutal ligament are of particular importance for the pivotal axis. Two structures which normally obscure this view of the middle ear have been removed. They are the chordae tympani nerve and the tendon of the tensor tympani muscle. Through the ossicles, the vibrations of the tympanic membrane are transferred to the footplate of the stapes. The stapes moves with a piston-like action, which sends vibrations into a structure called the Bony Labyrinth. The labyrinth is filled with a fluid called perilymph. If it were a completely closed and inflexible system, the movement of the stapes would be unable to displace the perilymph, and therefore unable to send vibrations into the bony structure. Due to the flexibility of a membrane called the round window, the stapes movement can displace the perilymph, allowing vibrations to enter the labyrinth. The corridor leading to the round window is found within the spiral portion of the bony labyrinth, known as the cochlea. Vibrations produced by the stapes are drawn into the spiral system. The movements of the membranes then send vibrations. The tympanic membrane is cone-shaped and articulates with a chain of three bones called the Auditory Ossicles. They consist of the malleus, the incus, and the stapes. The three bones pivot together on an axis shown here in red.
Full screen.
The pivotal axis is due to a series of ligaments which hold the bones in place within the middle ear cavity. The anterior malleal ligament and the posterior incutal ligament are of particular importance for the pivotal axis. Two structures which normally obscure this view of the middle ear have been removed. They are the chordae tympani nerve and the tendon of the tensor tympani muscle. Through the ossicles, the vibrations of the tympanic membrane are transferred to the footplate of the stapes. The stapes moves with a piston-like action, which sends vibrations into a structure called the Bony Labyrinth. The labyrinth is filled with a fluid called perilymph. If it were a completely closed and inflexible system, the movement of the stapes would be unable to displace the perilymph, and therefore unable to send vibrations into the bony structure. Due to the flexibility of a membrane called the round window, the stapes movement can displace the perilymph, allowing vibrations to enter the labyrinth. The corridor leading to the round window is found within the spiral portion of the bony labyrinth, known as the cochlea. Vibrations produced by the stapes are drawn into the spiral system and return to meet the round window. The portion of the spiral passage in which vibrations ascend to the apex of the cochlea is called the Scala vestibuli. The descending portion of the passage is called the Scala tympani. A third structure, called the Cochlear Duct, is situated between the Scala vestibuli and the Scala tympani. The cochlear duct is filled with a fluid called endolymph, and when viewed in cross-section, the membranes separating the two fluid-filled systems are visible. They are Reissner's membrane and the basilar membrane. The membranes are flexible and move in response to the vibrations traveling up the scala vestibuli. The movements of the membranes then send vibrations back down to the scala tympani. A specialized structure called the organ of Corti is situated on the basilar membrane. As the basilar membrane vibrates, the organ of Corti is stimulated, which sends nerve impulses to the brain via the cochlear nerve. The actual nerve impulses are generated by specialized cells within the organ of Corti called hair cells. The hair cells are closely covered by a structure called the tectorial membrane. As the basilar membrane vibrates, the tiny clusters of hairs are bent against the tectorial membrane, triggering the hair cells to fire. The entire basilar membrane does not vibrate simultaneously. Instead, specific areas along the basilar membrane move variably in response to different frequencies of sound. Lower frequencies vibrate the basilar membrane closer to the apex of the cochlea, whereas higher frequencies produce vibrations closer to the base. This arrangement is known as tonotopic organization. Together, this sequence of events is responsible for our acoustic perception of the world around us.
The organ of Corti is located in the cochlea, a spiral, three-chambered, snail-like structure, 10 millimeters wide, within a bony matrix. The organ of Corti extends from the anterior part of the vestibule and coils for about 2.5 turns around a bony pillar called the modulus. In cross-section, the uppermost chamber is called the Scala vestibuli. The oval window is situated at the base of this chamber. The lowermost chamber is called the Scala tympani. At the base of this chamber is where the round window is located. Both the Scala vestibuli and Scala tympani contain perilymph. Between the Scala vestibuli and Scala tympani is the Scala Media. This houses the organ of Corti, which is referred to as the receptor organ of hearing. The Scala Media is filled with endolymph. The Scala Media includes structures from the tectorial membrane, basilar membrane, and hair cells, which sense the mechanical forces. The hair cells are located between the tectorial and basilar membranes. Approximately 16,000 hair cells are within the cochlea. There are two kinds of hair cells, inner and outer hair cells. 95% of the afferent fibers are from the inner hair cells, the sensory receptors that communicate with neurons from cranial nerve 8. Outer hair cells receive mostly efferent input from the superior olivary complex. The filamentous structures that connect the tips of adjacent stereocilia are known as tip links. These are thought to amplify the forces in the area of the molecular sensors. How does sound enter the cochlea? Compression hits the tympanic membrane, causing the stapes to transfer force to the oval window. The sound travels down the Scala vestibuli, around the helicotrema, to the Scala tympani, allowing its fluid perilymph to mix. From there, sound moves to the round window. High frequencies are encoded at the base, and low frequencies at the apex. It is this property that leads to the tonotopic map along the basilar membrane. The manner in which the basilar membrane vibrates in response to sound is the key to understanding cochlear function. The hair cells are located between the tectorial and basilar membranes and are stimulated by the shearing force between the two caused by the pivot point of the two membranes. The pivot point of the basilar membrane becomes displaced. The tectorial membrane moves across the tops of the hair cells, causing the stereocilia to bend. The ionic environment of the compartments plays a critical role in signal transduction. The apical portion of the hair cell is bathed in high potassium solution, and the base of the hair cell is bathed in potassium poor solution. This causes the opening of mechanosensitive channels, allowing potassium to flow into the cell, leading to depolarization. This in turn opens calcium channels at the basal end of the cell, leading to vesicular transmitter release to stimulate the nerve. Because the relative voltage and potassium levels are low at the base of the hair cell, potassium flows out of the cell. This establishes that potassium flow through the cell is used for both depolarization, potassium in at the apex, and repolarization, potassium out at the base of the hair cell.
That's all about physiological things here, and there are so many theories are there, place theory, telephone theory, different theories are there. Von Beckersey has contributed a lot for the theories of hearing. So the rest of the things we will do in the theory class. Okay? Any doubts? Thank you.
Good afternoon, everybody. So we saw the small movie clip. Did you understand the complexity of hearing? Similarly, the smell, we getting smell also is a complex theory. So we know how much nature struggles to put so many things together, and when everything is there, we have luxury. We can hear. But imagine some things go wrong and they cannot hear, they cannot see, they cannot smell. These are things where things go wrong. So whatever normal is there, that's called as physiology. Any deviation from these is called as pathology. So in our subject we deal with all abnormal. That means our aim is to find out why it is abnormal, and we try to give a diagnosis to each. So that is the approach from physiology to pathology. So I have actually taken up a few things pertaining to the ENT. One is, in hearing we have only physiological changes. Otherwise it can be some middle ear lesions like cholesteatoma and a few minor things. Otherwise not much of pathology from the ear. Sometimes we get tuberculosis seen in the otitis media. Otitis media is a mid-ear infection. It can be acute bacterial or it can be tuberculous. Children suffering from this is common. So any discharge through the ear, we try to diagnose what it is, taking the material for culture and sensitivity. Apart from that, it's the nasal cavity and the maxillary sinuses which we are really interested in. In these cases, you find that there are some infections. It can be some allergic process or it can be tumor, which is commonly categorized as. I will show you bird's eye view, like a few minor things which are very important, and that is what you can understand at this stage. So what is rhinosporidiosis? Rhinosporidiosis, initially we thought it was a fungal infection, but now it is thought to arise from the infection of a protist. Okay, protista it belongs to. So this is a granulomatous disease which is commonly seen affecting the nasal cavity, the larynx and the nasopharyngeal areas. So this is caused by an aquatic protistian parasite that is called as Rhinosporidium seaberi. And this is known to cause a particular type of infection when people either swim or use water which is infected with this. So fresh waters which are infected with this are the common areas where we can acquire these infections. So bathing or working in stagnant water, especially the areas where they use the same water for cleaning the animals. So these things, especially in villages, they are going to cause these infections. Now how do they present to us? Initially it is just a running nose or maybe a mild edema of the mucosa, difficulty in breathing. But later, as the mucosa becomes edematous and it starts bulging downwards, it produces a polyp-like lesion. Can you see this polyp here? The entire nasal cavity is blocked by the edematous mucus plug. Can you see? So this is the one where you can see that this is completely occluded. Now the patient cannot breathe through this nostril. Sometimes it can be bilateral. If both are blocked, how do they breathe then? Okay. This is another thing where from the nasal cavity it is grown down to the nasopharynx and you can see the bulbous mass here. So that is rhinosporidium. So when you look at grossly, we may not be able to say what it is, but once it is excised, we find that the mucosal lining is seen. In the submucosa, you find such structures which are nothing but the Rhinosporidium seaberi, which is having a double chitinous wall, and these are the sporangiospores. Okay, so this one is the earlier one. It matures through all the stages, and once it reaches this full mature stage, this bursts open, and all of these are released outside. Each one of these will get deposited and start growing into a new lesion. Okay, so that is why it becomes very bulky and polypoid-like mass. Ultimately, excision is the answer. If it is excised completely, there may not be recurrence, but if some remain back, there can be local recurrences like the lymphedema. The other important feature is the nasal polyps. When it comes to nasal polyps, they are soft, painless, non-tumorous protrusions of the mucous membrane, and this can be seen either because of any allergic process or because of any pollutants. The common areas where you see is, can you see? Along the turbinates, the nasal mucosa, the maxillary sinuses, these are the common areas where we can see this polyps. Can you see? These are the commonest areas. So once they start growing like this, then there will be difficulty in breathing. The patient will always have a very stuffed nose and they cannot breathe properly. So what is the answer? We have to remove the polyp. Once it is excised, you can find this. Can you see it's a full polyp like this? The whole thing, actually it should be straightened out. It's in the form of a bent one. And this is the amputated area. So that is why it is bleeding. So this is the one which they send it for histopathology examination. We put this into formalin, fix it. After we fix it, we process it, we make blocks. We cut them, stain them with H&D, and just like how you see your histology slides, we make sections of these. So what do we actually see? Can you see the respiratory epithelium here? What is the epithelium? Normal. Deviated epithelium. And can you see the submucosa? It is markedly edematous and the cells are separated. And you can see the edema fluid. Can you see this? All acellular zones are the edema fluid which is being filling up. And all these tiny dots are the inflammatory cells. Okay? Is hypergamy of the same? Can you see the ciliated columnar? All of you agree with me? Okay. And can you see the edematous submucosa? And you can see all these inflammatory cells. Now when it comes to inflammatory cells, we as pathologists are interested whether they are just mixed inflammatory cells or do they have eosinophils. If it is just inflammatory cells, we pass it off as a non-allergic polyp. If eosinophils are plenty, we call it as an allergic etiology. Okay. So this is the importance of knowing what type it is. Here you can see a lot of eosinophils are there. Can you see this? Spectacle shaped nuclei and the eosinophilic dense granular eosinophilic cytoplasm. So these are all the eosinophils with plasma cells and of course a few lymphocytes in between, and you can see the lining epithelium. So this is an allergic polyp. Okay, because what cells are more? Eosinophils are. Now coming to the next, sometimes we find that the patient has irregular bleeding through the nose. The patient is feeling that stuffy sensation, they can have headache. And with all this, if it's an elderly person, we start thinking, is there anything else apart from the routine polyp or apart from the routine sinusitis or whatever. So in such cases, when we go back, we find that most of them tend to be smokers. It's common in men, tend to be smokers, and it is commonly seen in the 6th decade and above. Okay. The common areas which the disease presents and they can extend into is the nasal cavity, the paranasal sinuses. Sometimes it can even involve the orbit, skull base and brain. So in such cases an MRI is very, very important for us to know the extent of the disease. So when we take a CT scan, you can see that there is, can you see this? A tumor almost eroding the bone also. This is the tumor. And biopsy will be sent to us or an excisional specimen. If it is an accessible area, they are able to take a biopsy, they will take a biopsy and send. Otherwise, if they know it's a tumor and they operate, they will send the whole specimen to us. So we receive either an excisional biopsy or a tiny biopsy first, and then subsequently they may go for a planned surgery. So when we get a biopsy, what are we seeing here? Are we seeing sheets of cells? And these cells look different. Each cell looks different from the other. So there is pleomorphism. And when you look at the nuclei, can you see there are a lot of mitotic activity? Can you see this? These are all called as multipolar mitosis. Normally, what is the number of poles you get in a normal physiological mitosis? 2 poles, bipolar, isn't it? See, all of them look star shaped. Can you see the pointings going out like this? Yes? These are all the multipolar mitosis. Plenty of mitotic figures telling you that the cells are actively dividing. And tumor cells are known for their abnormal division and uncontrolled division. So they keep on growing and growing. So each day they will multiply into several times. So this is the morphology. So you find lot of pleomorphism. So each individual cell is a round to oval cell having moderate amount of eosinophilic cytoplasm. And you can see the nuclei which is sort of vesicular to hyperchromatic, and you can see plenty of mitotic figures. Amidst these tumor cells, can you see this delicate thread-like capillaries? Can you make out this pinkish? See here again. Here? Yes? So this is part of tumor angiogenesis. Tumor cells produce certain factors which stimulate the blood vessels to grow within the tumor, and they see to it that they get blood supply. So tumor cells are like parasites. So they produce some factors which stimulates the normal. The blood vessels, thinking it's a normal stimulation, starts growing, and there is tumor angiogenesis. The blood vessels grow into it and they start infiltrating into the tumor cells and supply nutrition to them. If suppose the tumor cells are growing so fast that the blood vessels cannot catch up with them, then what happens to the tumor cells? They are not getting blood supply and they are multiplied already several times. What happens to them? They get necrosed. So tumor necrosis is common in areas. So if at all a tumor is showing necrosis, it means they are rapidly proliferating cells. The blood vessels are unable to catch up with them. Okay, so that is the theory about tumor, that is nasopharyngeal carcinoma, which is known in the nasal cavity and the pharyngeal area. Any doubts? So regarding the nasal cavity, these are the common lesions. If it comes to the ear, I told you cholesteatoma, and if it is the throat, it's the laryngeal carcinomas which are common. So voice abuse is one of the commonest things which can produce laryngeal polyps and laryngeal carcinomas. Most of them turn out to be squamous cell carcinomas. Any doubts?
The necrosis of the tumor of which sign because it's not getting enough blood supply. Will it stop?
It's a good sign, yes, that it's not getting blood supply, tumor is dying down, but at the same time we are rapidly spreading elsewhere also, no? So it is both, it's like a sword with double edge. So one side it is, yes, it is getting necrosed, but at the same time it's rapidly proliferating. So spread through blood vessels, spread through lymphatic is again common. So they spread faster. Okay? Any more doubts? Thank you.
Aishwarya from Department of ENT. We'll be showing something about the little bit of anatomy intricacies of the nose, throat and the ear. Because as you know, the ENT deals with the problems in the small areas, and also we deal with the special senses. So because of the advent of endoscopes and other micro instruments, we are able to achieve a near total clearance of the diseases. Before that, we can go to the different small nooks and corners of the anatomy of the nose and parietal sinuses, and also a little bit of otology and a little bit of laryngology. Okay, we will show you first the anatomy, and we'll talk about the respective diseases. Okay, now she is doing otoendoscopy. If you pass an endoscope into the ear, it's called otoendoscopy. Endoscope is a small instrument which comes in different sizes. Adult one is around 4 millimeters, the pediatric is around 2.2 millimeters. With this, we diagnose many conditions of the ear, nose and the throat. It comes in different angulations. It comes in 0 degrees, 30 degrees, 45 and 70s. Usually 0 is used for otology and basic rhinology work, but as you go to 30, 70 and 45, it's advanced rhinology work and skull-based work. Now I think we'll start with the otology. Just see how does the ear drum looks like. Take over.
So what I'm doing is an otoendoscopy, basically looking at the nose with an endoscope. Like
Ear,
sir, the ear with an endoscope. So what, like sir said earlier, these are the components I just explained to you before I start. So this is the camera that I've attached to this. This is the camera that is attached to this. This particularly is the endoscope. This separately is the endoscope, and this is the light source that goes into the endoscope, right? When sir talked about degrees of endoscopy, that is 0, 30, what angles is the angle at which the tip points. So 0 is look straight forward, and then as the angulation goes, it turns that many degrees from the horizontal to look downward. So if you have to see, if you have to look at the larynx, if I pass an endoscope, a straight endoscope into the throat, the lens will look downwards, so it will be able to pick up something that is there down. Now for a ear endoscopy, we will be using a 0 degree endoscope which looks directly in front of the endoscope. It's a 0 degree, it's 0 to the horizontal. So we'll just show you what this is. So this is, since you know a bit about the anatomy, I'll just go into this. So this is the pinna, as you can see, and I'm Okay, so we'll just show you how the change happens from the cartilaginous part into the bony part. You will realize that in the cartilaginous part of the ear canal, there are hair follicles, and you will see hair within the cartilaginous part. And as you go into the bony canal, you will see there are no more hair follicles, and you will see just skin lining the bony part of the external auditory canal. And then at the end of it, you will see the tympanic membrane situated there. So we'll look at the tympanic membrane, and I think you will know the parts of the tympanic membrane, the pars tensa and the pars flaccida. What we're primarily concerned is about the pars tensa, and then the pars flaccida has a whole different set of clinical significance and clinical significance associated with it. So we'll just do an endoscopy, and I'll show you how the tympanic membrane looks, and if possible we'll just elevate it up, and we'll show you how the middle ear looks through the with an endoscope. Now this is the ear. As we are going in, you can see hair lining the, this is the cartilaginous part of the external auditory canal. You can see hair lining it. And as we go inside, you see the hair slowly disappearing, okay? We are entering the bony part of the external auditory canal, alright? And at the end, what you're seeing, that membrane is the tympanic membrane, alright? So this is what you're seeing, this is the tympanic membrane. This, what you're looking at face front is the pars tensor. This is the pars tensor, and above you'll get, it's not a very clear picture, it differs a little from real life, but this is how it looks, okay? So on top is the pars flaccida. Now you can also see how the tympanic membrane is angulated. You can see that this is the anterior part, that is the posterior part, okay? See, if you can look at how the face is oriented here, this is anterior, this is posterior. Now you can see the anterior is slightly away from, there is an angulation at which the tympanic membrane is situated within the ear canal, okay? So the anterior part of the tympanic membrane is slightly angulated away from you, okay? It's more medially. Okay, that is what it is. Now you can see, I don't know if you can appreciate the prominence on the tympanic membrane there, where there's a line that runs from maybe 11 to the handle. That is the prominence of the handle of the malleus. Now if you're aware, you know about the ossicles, you have 3 ossicles, the malleus, incus and the stapes. What is very prominently seen associated with the tympanic membrane is the handle of the malleus. That is what you will be able to see, the prominence of the lateral process and the handle of the malleus that you see through a tympanic membrane, alright. I just try to lift up the tympanic membrane if possible and this is what was done yesterday. We managed to just lift up the skin of the bony part of the external auditory canal. Okay, usually when surgeries are done, this is how it is done. You make a flap here, you make an incision here, lift this up, and then you get access to the middle ear. As you lift this up, now you know the tympanic membrane has 3 layers, okay, 3 primary layers. You have the epithelial layer, the skin over the external auditory canal, it continues over onto the tympanic membrane, forms an epithelial layer. You have a middle fibrous layer, and then the mucosa of the middle ear continues onto the tympanic membrane to form another layer on top, in the inside. Okay, now we have lifted up the tympanic membrane. Okay, peripherally the tympanic membrane is thickened to form something called a fibrous annulus. Okay, can you make out that thickening here, that white band kind of structure there? That is peripherally your tympanic membrane pars tensor thickens to form something called a fibrous annulus, which rests in a bony canal, bony sulcus here within the bone called a tympanic annulus. Alright, so now once we lift this up, the skin along with the tympanic membrane is completely lifted up, and what you're seeing inside is the middle ear. Alright, that is your middle ear cavity. Okay. Now I'll just point out some structures to you. Now on top, this here on top, what you're seeing, that is the long process of the incus, okay, and that is articulating with the stapes. Okay, this is the smallest bone in your body, so that is your stapes. So the incus, the long process, articulates with the stapes head, and then the stapes, the foot plate rests in the oval window, right? Okay, so that is the oval window where it is rest. Yeah. Okay, and now that is the round window niche that you're seeing inferiorly. So it's your secondary tympanic membrane or your round window niche. So now this is the promontory or the bulge, or the basal turn of the cochlea forms a bulge in the medial wall of the middle ear. What you're looking at is the medial wall of the middle ear. The lateral wall of the middle ear is formed by the tympanic membrane, which I've already lifted up. So you can see the medial wall of the middle ear inside. Okay, and here below is the hypotympanum. Okay, so your tympanic membrane divides your middle ear cavity. It's a lateral wall of the middle ear cavity. Anything above the level of the tympanic membrane, the middle ear cavity still extends above and below. Above is the epitympanum, and below is the hypotympanum. All right. We are not able to see the body of the incus because that rests in the epitympanum. Okay, so if you have to see the epitympanum, you will have to remove bone overlying the above the tympanic membrane to be able to access that area, right? And just in this is anterior. This is anterior, and behind is posterior. So eustachian tube opens somewhere here behind the tympanic membrane there. Okay. If you would have been able to lift this up completely, we would have been able to show you the shadow of the eustachian tube, the opening of the eustachian tube which opens there. All right. So you've understood brief what happens inside the ear and how the middle ear moves. All right. So when clinically, what is important for you is these tympanic membrane. The tympanic membrane is there. It's a very tough layer, but it can still get perforated. Holes can happen in the tympanic membrane secondary to either trauma. It can happen secondary to infections. This can happen where you have a hole in the tympanic membrane. Now, since you've listened to a physiology class, you know that the vibratory surface of the tympanic membrane is very important for sound transmission, correct? So, if the tympanic membrane, there is a hole in the tympanic membrane, there is no effective vibrations that are being transmitted from the tympanic membrane, and you know the aerial ratio and the lever ratio which transmits sound into the stapes, and the stapes pushes into the fenestra, your oval window, and that is how sound is produced, right? You've had a physiology class on it. So, you need to have an intact tympanic membrane for your vibrations to happen properly, for sound to get transmitted from outside to the inside. So, any breach in the way the tympanic membrane is placed, any problem with the tympanic membrane is going to cause reduced vibrations, and that is effectively going to reduce the transmission of sound into the inner ear. Okay, so that's about the ear. Do you have any doubts that you need to ask?
Conditions.
Yeah, we'll just talk about some pathologies that are related to the
Diseases
ear.
of the ear, sound diseases.
So
that is on the drum.
Yeah. So patients, when they come to you, the most common complaints that they're going to come to you as far as ear is concerned is either reduced hearing, right? That's one of the most common complaints you're going to have. So you're going to have reduced hearing. They're going to complain of discharge from the ear. Okay, blocked sensation. These are some of the common complaints that a patient comes. Ear pain. Okay, so these are common complaints that a patient is going to come to you with. Some of the relatively rarer symptoms are dizziness. Okay, because your inner ear, your labyrinth is related to balance. Okay, so that is important. So anything that affects your inner ear, patient can present with giddiness. Another important structure also you should remember, and a very important cranial nerve runs in relation to the middle ear. Okay, the medial wall of the middle ear, that's a facial nerve. Okay, so any infections or any trauma involving the ear can also affect the facial nerve indirectly, and the patient can end up with facial nerve paralysis. So that is why the ear is so important to us. Okay, now you saw the stapes. We showed you how the incus and the stapes are articulating. Right above the stapes, the horizontal segment or the tympanic segment of the facial nerve runs. Okay, so any infection in this area can directly affect the facial nerve, or even trauma for that matter. Okay, and even when you're operating, you need to be careful because you can end up damaging this. Usually the facial nerve is housed within a bony canal, so it's not very commonly that you end up injuring the facial nerve canal. But there are patients, or due to an infection, the bony canal is dehiscent. In such patients, they are much more prone to facial nerve paralysis. Okay, so these are some of the complaints that the patient presents you with. So when the patient comes to you, you take out a history, and then we start examining the ear and we rule out problems from the outside to the inside. Okay, so you look at the external ear first, look at the middle ear, and then you think about the inner ear problems. Okay, so some of the common problems, the patient comes to you with reduced hearing, the first thing that you have to rule out is ear wax. Correct, this is one of the most common complaints, because ear wax is situated in the external auditory canal, which again prevents sound transmission to the inside and blocks sound conduction to the inside, and because of which the patient will effectively complain of reduced hearing. So then you look at the external auditory canal. So you will see, when you examine the external auditory canal, you will see wax. Here also actually you will be able to see a little bit of flakes that are sitting in the canal. Okay, so wax can be thick, hard wax can be there, so you need to remove it. As we go progressively inside, another thing is perforations in the tympanic membrane, like I was talking to you about. The condition is called chronic suppurative otitis media. Okay, we'll be learning about it in the next couple of years. So you can have a recurrent infection in the middle ear which will cause rupture or perforation in the tympanic membrane. So because of which again the patient will complain of reduced hearing, because you have a big hole in the tympanic membrane that is not causing it to vibrate properly. Also, another problem when there is a hole in the tympanic membrane is your middle ear is now exposed to your external ear. Okay, so now external ear pathogens can very easily travel into the ear and cause repeated infections. So every time you go swimming, water enters your ear, you try to use earbuds to clean your ear, you end up introducing infection into the ear because there is a hole in your eardrum. Alright, so this can cause recurrent infections. And infection will manifest as discharge coming out of the ear, because your middle ear is lined by mucosa, which has a lot of goblet cells which secrete a lot of mucosa, and this mucus, and this starts coming out as discharge. Okay, when this gets infected. Alright, and so these are some of the common pathologies. There are other pathologies, like you were spoken to about otosclerosis, where there is fixation. I think you were spoken to about it, where there is fixation of the ossicles. So you need the ossicles also to move properly properly to be able to conduct sound from a tympanic membrane to the inner ear. Now even if a tympanic membrane is intact, if there's something that is causing the ossicles not to move properly, again you're going to have complaints will affect the ear. And there are other pathologies that will affect the inner ear. You can have labyrinthitis, where your inflammation of the labyrinth, which can cause severe giddiness. Alright. Another thing you should remember is, we cannot stress this more enough, because your ear, the middle ear, is related very closely to your cranial cavity. Okay, you have a very thin segment of bone that divides the brain from the ear. So even when you're operating or you think of infections, it's very commonly possible that infections can spread very easily from the ear to your brain, and even when you're operating, you need to be careful when you operate on that structures. Okay, so the roof of the middle ear is what separates your brain from your ear cavity. Alright, so these are some of the things that we are operating in a very small area. Okay, you should realize that we talk about a lot of things when you're talking about the ear, but ultimately all of this condenses into a very small area. So whatever we're operating on a very, very small area. Our instruments, like you see, are really small. Okay, it looks big when I'm using an endoscope because it's magnified. We use microscopes to operate on the ear, okay, because it's not possible otherwise to see what we're seeing. Millimeter, you move your hand millimeter this way, that way, you end up damaging some important structures. Okay, and each thing is very important. Important that you preserve all of these structures. Alright. We'll now we'll just go to the nose. We'll just try to show you the nose. There was a lot of muck yesterday inside the nose, right? We tried cleaning it out today. So we'll just try to show you what is inside the nose. Okay. Even for the nose, we commonly use a 0-degree endoscope because we need to see right what's in front of us. Okay, so whatever structures are there, as we go in with an endoscope, they're right in front of you. So a 0-degree endoscope is enough to view the structures of the nose. Sometimes when you need to look within sinus cavities, you have we do use angle telescopes. You use about 30-45 degree telescopes can be used to view inside the nasal cavity. Now the nasal cavity proper is divided, the nose itself, the cavity is divided into two, on the right and the left, by something, a midline structure called the nasal septum, correct? You know there's a bony and a cartilaginous part of the nasal septum. Now I'm in the right side nasal cavity, so what sir is pointing at is the nasal septum, okay, which is medially, okay? And on the lateral wall of the nose, you have some important structures. So what sir is pointing at is called the inferior turbinate. You have three turbinates within the nose. You have an inferior turbinate, a middle and a superior turbinate. So this, what we are looking at, is the inferior turbinate. The area below the inferior turbinate is called the inferior meatus, where an important structure opens. Your nasolacrimal duct from your eye, the lacrimal sac, the nasolacrimal duct opens into the inferior meatus. Okay. This is where it is. Okay. So tears, when are secreted in the eye by the lacrimal gland, by capillary action, it moves into the medial canthus, and then it's pumped down into the nasolacrimal duct, and it drains out through the nose. Okay. So this is how tears are. So if there's any obstruction at this level, the patient will complain of excessive tearing because it's not getting drained into the nasal cavity. Alright. So that is the inferior turbinate and the inferior meatus. Okay. Now I will just show you above. You can see that bulbous structure that you're seeing there. That is the middle turbinate. Okay. So the area between the middle turbinate and the lateral wall or here is the middle meatus, which is a very important structure clinically, because this is also called the osteomeatal complex area, because you have paranasal sinuses that open into this area. Okay, you have the maxillary sinus, the frontal sinus, and the anterior group of ethmoid sinuses that drain into this area. So as it is, it's a very narrow area. So any small structural pathologies that affect this region or any inflammation in this region will cause an obstruction of the ostium of these sinuses, and this will cause collection within the sinuses and cause features of sinusitis. Alright, and you will end up with, after a cold, you end up with the facial fullness, heaviness, headache. This is all because of this. Alright, so this area is very lot of significance to us, this middle meatus area. Okay, so that is the middle turbinate. Okay, now what you should remember is the nose is separated laterally from the eye. Just lateral to the nose is the eye. Alright, so there is a very thin piece of bone that separates the eye from the nose, which is called the lamina papyracea. So again, like I was telling you, when we operate in this area, when you're operating in the middle meatus, you should be very careful. You go a little bit laterally, you will end up damaging the lamina papyracea, and then you're right into the eye. Okay, but there is the periosteum of the orbit that actually protects the eye from the nose. But nevertheless, very commonly sinusitis, when not properly treated, or patients do not come to you early on in the course of sinusitis, they end up with orbital complications. Okay, the infection can spread to the eye, and they end up with eye swelling, cellulitis, and preseptal cellulitis, orbital cellulitis, and it goes on. Okay, it can go progressively becoming worse. Okay, so again, so that is another important structure. Another thing, now I go right above. Okay, so right above what you're seeing here, yes, that is the skull base. That's a cribriform plate, okay, where your olfactory fibers open into the nose. Now again, this area is of very prime importance because right above that is your brain. You have the anterior cranial fossa right above it. So while operating, you make sure that you do not breach these boundaries. You have a set boundaries within which you are operating. Now, like the ear, even in the nose, you have a small space in which you are operating. Always respect your boundaries. Do not go laterally into the eye. Do not go superiorly into the brain. Okay, not only superiorly, we'll just show you how the skull base again progresses as we go posteriorly. All right. Now, I'll just try to show you the nasopharynx. Now, this is the inferior, the floor of the nose. All right. Now, I'm going to go all the way inside. Okay.
The whole thing is the nasopharynx.
That is the nasopharynx. Okay, that is the back of your nose. So this is the nasopharynx, and where your eustachian tube opens on either side. Alright, you have a eustachian tube opening on either side. So you have any infection in the nose, any infection or any mass. In children you have adenoids, okay, adenoid tissue, it's basically lymphoid tissue in the back of the nose that proliferates, which will cause obstruction. Yeah, that is the eustachian tube. Which will cause an obstruction in this area, will cause infections to spread to the ear, okay, and that is how you get ear infections after a cold. All of you would have noticed at some point of time or the other, if you had a cold, you complain of ear block, you feel your ears are blocked. This is because of this. Your eustachian tube gets blocked, and because of which you will have that ear block sensation. After it's quite commonly you have. Again, while you ascend and descend, either flight, okay, when you ascend up and come down, your eustachian tube gets blocked because eustachian tube is primarily responsible for maintaining the pressure difference and for ventilation between the ear and the nasal cavity. Okay, so anything that changes this can cause an obstruction and will cause changes in your ear. Alright, so that is the nasopharynx that we saw now. Okay, so that was the nasopharynx. Below is the soft palate. It's that other surface of the soft palate that you're seeing. Okay, you're seeing the superior surface of the soft palate. Now from here, I go right above. So I'll just try to show you the superior turbinate. Yeah. I'll try to show you the superior turbinate. It's not as easily visualized as the middle and the inferior turbinate, alright? So we need to push the middle turbinate slightly laterally to be able to go and visualize. Now the structures are very hard because it's formally preserved.
One bulge you can see, suppose see a bulge, that's the superior turbinate. Is the
Okay, it's a very small, it's not a very prominent structure like how you look at the middle and the inferior turbinates. Alright, so the superior turbinate is situated way behind and medial to the middle turbinate. Okay, now I'll just show you the sphenoid sinus if possible. So go straight to the back of the nose and you lift it up. Okay, somewhere here in this region is where your sphenoid sinus. Okay, so the paranasal sinuses are your maxillary, frontal, anterior, posterior walls and the sphenoid sinus. Now that is where your sphenoid sinus opens. Now if you know your anatomy, sphenoid sinus is situated right in the middle of your head. And what is an important structure that is located right behind the sphenoid sinus is your pituitary gland. Okay, so what we would like to emphasize here is that earlier when there were lesions involving the pituitary gland, we had to go transcranially, okay, to approach the pituitary gland and to operate in these regions. Nowadays things have become so much more easier. A lot of tumors intracranially are we are able to access it via the nose, okay, because this is directly related to this. So if you have to do surgeries for pituitary tumors, we pass into the nose, into the sphenoid sinus and open the wall and then access the pituitary. So you end up with no surgical scar at all in these patients. Alright. So it's very easy nowadays because you have endoscopes to access the brain and the area around this through the ear and through the nose. Alright. So this is how important endoscopes have become now. Okay, it's not just limited to ENT. The scope has widened drastically. There's a lot of things that you can do just with endoscopes. Alright. So these tumors become very easy for us to handle now. So you've understood something about the nose. Now just briefly about pathologies that can be that can involve the nose. Like I told you, Your nasal septum is usually supposed to be a midline structure, can be deviated to any one side. Okay, that's called a deviated nasal septum, which will predominantly result in nasal block affecting that particular side. If it's deviated to the right, the patient will complain of a right-sided nasal block. If it's deviated to the left, the patient will complain of a left-sided nasal block. So in those cases, we need to consider surgery to correct that deviated septum to make sure it comes back into a central position so that the patient will have some relief of breathing. Other things that can affect the nasal cavity are polyps. Okay, so because it becomes hypertrophy, they can become polypoidal, again cause nasal obstruction. So very commonly, most of you, either you know somebody or one of you itself might have allergy symptoms, right? You wake up in the morning sneezing, you go out to the dust, you start sneezing. So patients with allergy are very prone to developing nasal polyposis. Okay, so these are again when a patient comes to you with extensive nasal polyposis, you consider surgery, you pass endoscopes into the nose, and you start debulking the polyps. Okay, so this is how endoscopes use. So you end up with no external scar. Even when you're correcting the deviated nasal septum, the surgery is from inside the nose, you have no scars on the outside. Alright? Right. Now, we'll come down into the neck now. Now, usually for us in a clinical setting, if you have to evaluate the larynx is not situated in your line of vision. You can't pass straight, it's not in correct your line of vision, not able to visualize these structures. So clinically, when you have to evaluate the larynx, we use either mirrors which are angulated. Okay, they call indirect laryngoscopy mirrors, which are straight rods with an angulation at the end, and there's a mirror there. So you pass it to the back of the throat, it looks down, so it shows whatever it's looking at down. Okay, so there's a bend like that. So it picks up whatever image is there below, you see it in the mirror and you see it outside. So that's how you need to visualize it. Now further, this is what was being used, it's still used. Yes, it's definitely a very important clinical tool when you don't have endoscopes. But now when endoscopes have come in, you have angulated endoscopes. The tip is angulated, like I said, it looks down. So we usually use a 70-degree and 90-degree endoscope to look into the larynx. Okay, so it will look exactly like this. When you look from far away, it will look exactly like this. There will be a camera, there will be a straight run, but the tip will be looking downwards. So what we have to do when you have to examine a patient who comes with some complaints of voice change or a breathing difficulty or something, you're expecting something to be there in the larynx, you just depress the tongue, you pass the endoscope back into the tongue, and then this thing looks down and picks up visualization from the larynx and the pharynx. Okay, so that's how we usually visualize. In this, we will not be able to show you that because it's difficult to open the mouth. You need to have good mouth opening to be able to visualize the laryngeal structures. So instead, if this is cut at the level of the trachea, we'll go from below upwards. Okay, retrograde, and try to show you some structures. Alright, it will not be exactly how your anatomy picture is, but you will get an idea as to what is situated where and how it is. Now this is your neck, since you all have done dissection. Now this is the thyroid cartilage, okay, and you have the cricoid cartilage here, and below is the trachea beginning. Now I will go through the trachea, okay, and I'm going upwards now. What is the structure that I'm looking at? Can you see a slit there and two structures there? Yes, these are the vocal cords, okay. These are the vocal cords that we are looking at. So two vocal cords on either side. Okay, now I'm going to go through the vocal cords. I'm going above, okay. Now I'm going above. Now I've reached above the level of the vocal cords. What is this cartilage that we are seeing here? Yes, what is somebody said. Yes, that is the epiglottis. Now I go behind, I go again further upwards from the epiglottis. What I'm seeing there is the soft palate, the uvula, right? The soft palate. And behind that, if I go, I'll get the nasopharynx. Okay? What we saw earlier when we did a nasal endoscopy and we showed you the nasopharynx, this is the view from below. Okay, so this is how this looks. Alright, now the importance, see, larynx is a very, very important structure as far as clinics is concerned, because it has got mainly two functions. The main function of the larynx is for you to, it's got protective function, and it is an open airway into your, it is the opening into your airway. Okay, this is what you breathe in, air enters into the larynx and is directed towards your lung. So any pathology involving the larynx, is any growth there, any swelling there, will cause an obstruction of airflow from the nose down into your lungs, so you're not able to breathe properly. The patient will have breathing difficulty because there's some obstruction there. So this is very important. The other functions of the larynx is it's got a protective function, correct? It protects your airways from any foreign object that goes inside. You ingest something, you suddenly inhale something, you drink water, if it's going to get aspirated, you suddenly cough it out. That's because your vocal cords suddenly close, your larynx closes off, pushes whatever foreign body is there out of your body, tries to throw it out. Okay, so it's not very easy for you to aspirate something for it to enter the lungs. Okay, because the larynx has got a very strong protective function. Okay, this is very important. Now, the other function of the larynx, like you saw the vocal cords, when the vocal cords come together, they vibrate and they produce sound. So that's how phonation happens. Okay, so these are the important things related to your larynx. Now, another thing we'd like to stress upon is a very important a dire emergency in ENTs. This is what it is. Okay, we need to be in the hospital in 2 minutes when you're called. Is when there is an airway obstruction above the level of the trachea. Somewhere in the supraglottis at the glottic level, there's some obstruction. The patient is not able to breathe. There is no inlet of air for the patient to breathe now because there's an obstruction above, the patient is not able to breathe. At this point of time, the only thing you can do to save the patient is you make an opening in the trachea. Below the level of an obstruction, you make an opening, open the airway so the patient starts breathing from here. Okay, so this is an emergency surgery that you do for the patient to be able to breathe. So you make an opening in the trachea, open up and we put a tube inside for the patient to be able to breathe. This procedure is called a tracheostomy. Okay, so this is an emergency procedure. It is a life-saving procedure for a patient, and it's important that everybody knows the basics of how this is done. Okay, so around the first and the second tracheal ring, you make an opening between two tracheal rings, enter into the trachea, put a tube there so the patient will be able to breathe through that. All right. So that's. I think we've managed to impress the clinical importance of ENT on you. If you have any doubts, you can clear it right now.
Anything you didn't understand or you want to have some more clarifications, you can ask.
Nothing?
Any questions?